Welcome to the Impact Institute. I'm Dr. Kimberly Summers. I'm an instructor for the Impact Institute as well as a physical therapist for Impact Physical Therapy. I also teach for Franklin Pierce University. I'm an assistant professor for them. Today we're going to talk about myofascial cupping. I'm really excited to share information about this manual treatment with you because it's something that's really easy on our hands and it's easy to modify in terms of the intensity for different patient populations. You can apply it to different fascial trains all over the body, and it's something that's been really helpful for us for improving patient outcomes and patient function. We're going to start with the history of cupping today. We're going to go into different variations of cupping, the evolution of cupping tools. We'll also talk about mechanisms of cupping and a few other ways to apply it so that when we get into class we can focus on different actual techniques and a lot of lab time. So let's start with the history. Cupping was developed over 5,000 years ago. It's cited in a lot of ancient Egyptian, Chinese, and Middle Eastern cultures in medical textbooks. It's typically cited as cleansing the body of impurities. There are multiple accounts of it being used to suck toxins from insect bites, but the take-home message here is that cupping has been around for a very, very, very long time, and it's been really helpful. So it's something that we would love you to be able to integrate into your practice in the clinic. Here are a couple of examples of different types of cupping tools. So prior to the 20th century, buffalo horns, metal, typically copper, and bamboo were all used for cupping. Up in Canada, there's also documented instances of using shells to create suction and used as a medical device. About the 20th century, valve cupping was developed. Initially, we used glass tools with this hand-operated pump. In the class, you will be using a plastic set, which is wonderful. You don't have to worry about them shattering and breaking. One other thing to discuss is that prior to the 20th century, obviously because we didn't have that valve, fire cupping is what was used. We will not be learning about fire cupping in the course. This brings us on to variations of cupping. Wet cupping is when you use typically fire, although you can use a valve. You make little incisions in the skin, and then the suction helps not only to separate fascial lines but also to suck out morbid humors from affected areas. Fire cupping in this picture, there's a piece of cotton that was lit on fire, so it's creating negative pressure inside the cup, and then the cup is applied to human skin. Obviously, there's always a risk of burns with that, so we'll be using valve cupping in the course again with a hand-operated pump. That pump allows the practitioner to easily modify the intensity of the intervention, so we'll go over all of that in class. Next, let's talk about the theory of cupping. So we're using negative pressure to loosen myofascial units to increase blood flow, and this pressure, this input of mechanical suction, also helps to sedate the nervous system, which allows our patients to maybe move through different ranges of motion or perform different functional movements with decreased pain. The use of suction helps to rapidly facilitate rigid soft tissue release. This helps with decreasing a patient's blood stasis, decreasing areas of stagnation. On to the mechanism of cupping. The suction can create hyperemia, so it really improves circulation to the area and helps to increase blood flow. This increased blood flow can help with flushing out toxins, helps to flush out the lymph system, and resupplies vital nutrients to the area. There was a study done looking at hematological factors before and 7 days after cupping, and then again 14 days after cupping, that showed significant reduction in ESR, your erythrocyte sedimentation rate, which is used to help diagnose chronic inflammation, including cancer and autoimmune diseases. So that's just one study that has helped us show that cupping actually does decrease inflammation. It can also help facilitate muscle relaxation, thinking about that neuromodulatory effect. So again, the physiological effect, anti-inflammation, helps facilitate remodeling and repair by bringing in fibroblasts to the area, and then the neuromodulatory functions because we're stimulating those proprioceptors in the fascia at the site of dysfunction. Again, the negative pressure lifts the skin. It does cause damage to capillaries, which increases blood flow and stimulates proprioceptors as well as pain receptors, as well as separating fascial layers, breaking adhesions, and ecchymosis will occur. In the class, we will go over different colors of the skin that can happen when you're applying cups to the skin that will help you apply the appropriate dosage to help facilitate healing and decrease the risk of that extreme bruising or any negative sequelae. Now let's talk about different benefits that cupping can have for the practitioner. Because it's so easy to apply and because we're going to use a valve and a pump, there's decreased strain to the practitioner, so we really get to save our hands. We know after an 8 or a 10-hour day in the clinic, we're seeing patients, maybe every hour, maybe every 15 minutes in a really busy outpatient orthopedic clinic. So when you have the ability to utilize a manual technique that's really easy, it can help you save time and improve outcomes. It also allows you to have multiple points of contact at once. So we're not just going to learn how to apply one cup, but we'll also learn how to apply multiple cups to different areas of the body. And then maybe it's your first treatment and you're having your patient just lay prone and they're static, but maybe they're really healthy, they're an athlete, they can tolerate multiple cups, and you can do cups throughout an entire fascial line. So really get a lot of bang for your buck, a lot of, you're just able to accomplish a lot manually. Again, we've already mentioned that it's a decompressive manual technique. We've talked about the increased blood flow. One of the other things you can do is use cups over actual incisions, obviously healed incisions, but maybe following a total knee, you've got a lot of maybe keloid scarring, just it's really bound down. You can use cups, either static or sliding, to help improve incisional mobility, and then you'll see great outcomes with your patients gaining knee extension and knee flexion range of motion. We've also talked about the intensity already, so low intensity static. You can even do a half a pump or a pump, high intensity, 3+ pumps. Maybe the pups are sliding and your patient's moving, so we'd call that sliding on dynamic. Or maybe your patient has static cups on, but they're moving through a large range of motion. More benefits to the patient. We've talked a little bit about pain control, but you're really trying to stimulate those ascending pathways to inhibit that pain signal going all the way up to the central nervous system. This can help with desensitization of hypersensitivity. And again, most of the research that's been done really supports that cupping helps with that neuromodulatory effect. Our end goal here is to really stimulate those proprioceptors to desensitize an area and help facilitate healthy movement patterns in pain-free ranges of motion. So we've mentioned a little bit about the evidence, but what does it really tell us about cupping? A lot of studies have been done, and multiple studies support a direct and an indirect physiological response to cupping. We've talked about toxins, the lymphatic system, increased circulation, which is very evident when you just look at the site of where you apply a cup. It's also been shown to improve the visual analog scale and the Oswestry Disability Index when compared with usual care, so analgesics, heat, no treatment when we're treating acute low back pain, chronic low back pain, as well as nonspecific low back pain. There's also been studies done that show there's decreased disability in patients with chronic neck pain when we've compared cupping to medications or no treatment. It's also been used to treat E-stim. A study was done where they compared E-stim to cupping. The patients were treated 2 times a week for 4 weeks, and their pain decreased and their disability decreased when measured on the lower extremity functional scale and the foot and ankle ability measure. It's important to note that a lot of this evidence, although significant improvements were shown in pain and outcome measures, most of the conclusions of these studies show that it's important for more research to be done, because a lot of these trials, although they had statistical significance, there, as in all studies in physical therapy, there's always improvements that can be made to help strengthen those studies. So let's talk a little bit about evidence-based practice. So remember, there are a lot of components to evidence-based practice. It is not just research. So in green here, we have best research evidence, right? So when we've talked about how the quality of a lot of cupping studies does need to be improved, there are more cupping studies that came out in 2017 and 2018, and more being done. There's 4 studies currently that are being done at Franklin Pierce, looking at cupping, improving forward fold, improving dorsiflexion range of motion, improving back pain disability measures. So just remember, research, extremely important, but it's only one prong of evidence-based practice. So the other prong is your clinical expertise. So what have you seen in terms of patient outcomes? What are your strengths? In terms of your decision making, what helps you as a clinician help improve your patient outcomes? And then we're also always need to take into account our patient values and preferences. So if our patient really can't tolerate dry needling, it's something they're very against, then that's not a treatment that we should ever use. So when we're thinking about evidence-based practice, what our patient thinks, feels, what their values are, their culture, their preferences, it should play a large part in your clinical decision-making model. So one of the benefits of using cupping is it's something that is, because you can modify and tailor the intensity, a lot of patients, they'll come back time and time again asking not only for you to do the intervention of cupping, but also to learn how to use cups themselves in order to help with self-management. Okay, different techniques that we will go over in class: stationary cups on static patient, sliding cups on a static patient, stationary cups on a dynamic patient. So your patient maybe is doing something as simple as just ankle pumps while they're lying in prone while you're cupping their plantar aponeurosis, or sliding cups on a dynamic patient. So an example of that would be your patient is doing a forward fold and you're slowly sliding cups down their paraspinals to really help those fascial layers separate. We'll go over different techniques and what we feel, what variations help the most for different diagnoses and different impairments. So let's talk a little bit about specific scenarios when stationary cups on a static patient are indicated. Typically, this is what we start out with. So we don't start out with a really complex cupping treatment, really just like any manual intervention or even therapeutic exercise. You're going to start simple, look at your test retest, and make sure that your patient is gaining a benefit from it. So if your patient is in symptom modulation, so they're really acute, highly irritable, maybe they're in an elevated emotional state, or they have a localized trigger point, those are all reasons or situations where we would start with static cups on a static patient. Currently, there are no guidelines existing for the specific duration, but typically in research studies and what we use in the clinic, we apply the cups for 5 to 10 minutes max. I would say typically if it's a static cup on a static patient, even 3 minutes, you'll see a big change. I think that it depends on the intensity. If the intensity is pretty low, you're using half a cup or half a pump or a pump, maybe it's on a little bit longer. If it's a little more extreme, maybe 3+ pumps, then we're gonna go more towards the 5-minute dosage. Observation is key in order to determine when to take the cups off, so a medium red is preferred. We'll show you in the class a little diagram of different colors. We're really not going for that like black ecchymosis or bruising, really going for that medium red. Empirical dosage and duration, so 30 seconds for an initial application followed by a test retest. Again, patient tolerance, their skin color, and their preference are all going to help you determine what your dosage should be. And again, that's going to help you know when to remove the cups. Sliding cups on a static patient, so this is when you're slowly moving the cup when there's some suction applied to the skin. This is appropriate if your patient has responded well to soft tissue mobilization but continues to present with deficits. If they had a positive response to static cups. It's really wonderful, like I said, and the lower back can also be used on the upper traps. Helps with improving range of motion along the muscle belly and to decrease fibrotic scar tissue. So just be cautious with this technique over the IT band, the plantar fascia, and then the upper extremity, especially the medial aspect, just because those areas can be extra sensitive, and especially the upper extremity, the skin there is a little bit more fragile. Sliding cups on a static patient, initially one full pump, really you could use a half a pump. The reason that we decided on one pump is because the cups don't fall off, so it's going to depend on the tissue quality of your patient. The tension of the skin, higher tension is going to require a little bit more higher intensity in terms of the pumps for the cup to stay on while you slide it. It's really important to apply lotion. We never slide cups on just dry skin. We'll apply lotion, whether it's a static cup or a sliding cup, but we'll apply a little bit more when it's sliding. Again, sliding increases the intensity of the treatment. Next, let's talk about static cups on a dynamic patient. So here you'll see Eric with a patient in kind of quadruped doing a reach in the frontal plane, helping with side bending, while the cups are static on her back. So a little more intense. Again, it's a progression of a cupping treatment. It can help with improving a faulty movement pattern. So Eric's able to apply tactile cues as well as manual intervention throughout the paraspinals using this treatment technique. So let's talk about the application of static cups on a dynamic patient. We'll typically do 10 to 20 reps of a movement. This is to help with neuro re-education and to improve those faulty movement patterns. Typically, we'll tell patients to move really slowly initially because the sensation we'll show you in class can be pretty intense, like a pulling, almost like a ripping, but I would say ripping is a very strong word. Also, make sure you warn your patients that the cups might fall off. Simply replace them in the same location or reposition if you want them to continue to do more repetitions. We'll go over all that in class. So now sliding cups on a dynamic patient. This is the most aggressive form of treatment of myofascial release using cupping. It's appropriate for higher level patients in good health, so great tissue quality, good hydration. You can tell that your patient eats well, they're well rested. If fascial restrictions are present throughout range of motion, it can really benefit to put cups on and then slide the cups while your patient is moving through those range of motion deficits. Also, if your patient has responded really well to static cups on a dynamic patient, but you just need a little bit more, a higher intensity to help improve their function. Also remember, open chain is always less painful than closed chain. So if you've got some restrictions in your quad and we apply it to maybe the VMO, distal vastus lateralis and vastus medialis, and you have your patient go through a long arc quad, that's going to be much less intense than having them squat. Okay, let's talk a little bit about clinical decision making and cupping. So we've talked about applying cups to a trigger point or fascial restrictions, but it's important to palpate and determine where those restrictions are throughout a fascial line. It's going to help you make the most change in your patient. Common locations, trigger points, fascial densification, restrictions in the myofascial unit. larger diameter cup over larger areas, a smaller cup over smaller areas. An example of that would be like the plantar fascia or the upper trap. By taking advantage of your palpation skills, it helps you identify all of the areas of densification throughout fascial lines so that you can improve fascial gliding throughout the entire fascial train to help with functional movement. We'll go over that in class. Really, the clinical pearls here are that it's important to assess the kinetic chain not only with palpation but also with observation. So you're always going to pick your test, retest before you apply your cups, or really before you do a manual intervention. We're all really familiar with that. Following your intervention, you're going to solidify the change with a corrective exercise to help your patient maintain the changes that you help them with. So how do you determine the number of cups that's appropriate? It really depends on what you find with your palpation techniques. It depends on the tolerance of your patient. Also, remember that if you cup over multiple muscle groups, you will help to improve a common movement. It's also possible if you have that mechanosensitivity of a peripheral nerve, you can apply cups over peripheral nerves throughout a tract to help improve gliding and decrease the sensitivity of that nerve as it slides through fascia. Okay, so we've talked a lot about the history of cupping, theory of cupping, mechanisms, a little bit about the evidence behind cupping and different ways to apply the cups. So in class, we will go over different techniques specific to all of these fascial lines, as well as different ways to assess and reassess these fascial lines before and after your cupping techniques, and then we'll follow them up with corrective exercises to really help your patient maintain those functional gains. I'm excited to share myofascial cupping with you, so have a great day, and we'll see you soon.